We define traumatic brain injury as a disruption to the normal brain function and structure that occurs as a result of an external physical force to the head. Most commonly, this external force is either through a blunt impact injury to the skull, for example, that received during a fall or a road traffic collision, or via a penetrating injury, such as a stabbing or a ballistics injury. The symptoms of traumatic brain injury may be cognitive, motor, or they may be sensory in nature, depending on the extent and the location of the injury. Regarding the severity of traumatic brain injury, we typically classify them as either mild, moderate, or severe, and we shall focus more on this later on in the tutorial series. An important definition that we need to be aware of in patients with traumatic brain injury is primary brain injury and secondary brain injury. In primary brain injury, this describes the injury which occurs at the time of the trauma, and it may include concussions, brain contusions and lacerations, and also intracranial hematomas. Whereas in secondary brain injury, this occurs as a result of a cascade of metabolic and cellular events which have been triggered by the primary brain injury event. And interestingly, it's the secondary brain injury that forms the focus of our management when we deal with patients who have traumatic brain injury. And we'll be coming back to this in more detail later on in the tutorial series. To be able to fully comprehend traumatic brain injury, we have to make sure that we have a sound knowledge of the anatomy of the skull, the brain, the layers which cover the brain, the blood supply, and also the other contents of the cranial vault. We'll start with the bony anatomy. The bones which form the cranial vault, so the cavity of the skull which houses the brain, consists of the frontal bone, the sphenoid bone, the ethmoid bone, the temporal bone, the parietal bone, and the occipital bone. The joining of these bones along their various sutures creates the hollow cranial vault, which houses and protects the relatively delicate cerebral hemispheres and the cerebellum. However, rather than the brain just being a free-floating structure within the cranial vault, it is further supported and protected by a complicated series of tissue layers, which line both the inner aspect of the skull and the brain itself. These layers, which are collectively referred to as the meninges, play a pivotal role in both the physiological activity of the brain and also its physical protection. As well as covering the brain, the membranous meninges also continue to cover the spinal cord. The meninges consist of 3 layers. The outer layer is the dura mater, the next inner layer is the arachnoid mater, and the very innermost layer, which sits directly upon the brain, is the pia mater. The meninges have 2 main functions. It provides a supportive framework for both the cerebral and the cranial blood supply, and also, acting with the aid of the cerebrospinal fluid, or CSF, the meninges protect the brain and spinal cord from significant mechanical damage. So essentially, almost being like a shock absorber for the brain during fast movement of the head. Taking a closer look at the different layers, the outermost meninges, the dura mater, lies directly underneath the bones of the skull and the vertebral column. It's a thick and relatively inextensible layer. The dura mater may actually be subdivided into 2 sheets of tissue. These are the periosteal layer, which lines the inner aspect of the skull bones, and the meningeal layer, which lies deeper to the periosteal layer. It's actually between the 2 layers of the dura mater where we find the dural venous sinuses, and these are responsible for being the main source of venous drainage of the skull and drain into the internal jugular veins. The dura mater actually has its own blood supply, and this comes from the middle meningeal artery. And as we'll see later on in this tutorial series, this artery is a key factor with regards to trauma which results in an epi or an extradural hematoma. Another feature of the dura mater is that at certain areas within the skull, it forms thick inward projecting folds which actually subdivide the cranial vault and brain into 3 compartments. These folds are referred to as the falx cerebri and the tentorium cerebelli, and they divide the cranial vault into the right and left supratentorial compartments and the infratentorial compartment. By compartmentalizing the skull, these dural folds help to reduce and limit the amount of movement that can take place by the brain inside the skull. However, they actually have a really important role when we start to understand the pathophysiology which occurs in patients who've had a significant traumatic brain injury, something we'll come back to later on in this tutorial series. Moving inwards, the next layer of the meninges is the arachnoid mater, which is the middle layer and lies directly underneath the dura. Underneath the arachnoid mater is a space which we refer to as the subarachnoid space. And this is important because it contains the cerebrospinal fluid, or CSF. And it's this fluid which helps to cushion the brain during movement. There are small projections of the arachnoid mater, which we refer to as arachnoid granulations. These arachnoid granulations project into the dura and allow CSF to enter the venous circulation in the dural space, and thus allow CSF to be drained. Continuing inwards, the final meningeal layer is the pia mater. This is located underneath the subarachnoid space and is a very thin tissue layer which is tightly adhered to the surface of the brain and spinal cord. The pia is so closely adherent to the brain that as it covers and protects the brain and its blood vessels, it actually follows the contours of the brain which are formed by the gyri, sulci, and the fissures. As we've mentioned, traumatic brain injury can be defined as primary brain injury, in which the injury to the brain itself occurs at the moment of trauma, or it can be defined as secondary brain injury, in which the injury occurs as a result of a cascade of cellular and physiological complications as a result of the initial injury. These complications can include oxygen and perfusion impairment, metabolic disturbances, cerebral edema and inflammation, and ultimately, elevation of the intracranial pressure, or ICP. And it's this last point, so a rising intracranial pressure, which can lead to deadly consequences by resulting in brain herniation. Now, as primary brain injury happens at the moment of injury, there's very little as medical practitioners that we're able to do to interfere with this process, other than promoting safer activities to prevent the initial injury from occurring itself. For example, the use of car seatbelts and cycling helmets. But from a medical or surgical perspective, it's the secondary brain injury that forms the focus of our attention. To be able to manage patients with traumatic brain injury, it's really important that we have a good understanding of the pathophysiology which happens during this phase, and in particular, during a rising intracranial pressure. To explain things a bit easier, let's simplify it a bit. So the skull itself is a rigid structure which contains a limited and fixed volume of space, around 1700 millilitres. Now, the contents of the cranial vault consist of 3 components. The brain, which is around 1400 millilitres. The blood, around 150 millilitres. And the cerebrospinal fluid, or the CSF, again around 150 millilitres. Because of the fixed volume of the skull, these 3 constituents exist in a dynamic equilibrium, which helps to maintain a relatively consistent intracranial pressure. So any increase in volume in one of the 3 constituents will be compensated by a decrease in the volume of one of the other 2. This dynamic relationship between the intracranial contents is named the Monro-Kelly doctrine, or hypothesis, after the 18th century Scottish physician and surgeon who initially described it. The importance of this equilibrium in maintaining intracranial pressure becomes much more clear when we look at patients who have traumatic brain injury. So if our head injury leads to a fourth factor taking up space within the skull, for example a contusion, hematoma, or cerebral edema, then initially, in keeping with the Monroe-Kelly doctrine, will be compensated by a reduction in the volume of either CSF or venous blood, in an attempt to maintain a consistent intracranial pressure. The problem comes, however, from when the volume of this fourth factor continues to increase, as there's only so much and so far that the volumes of blood and CSF can fall to help to compensate, and eventually will reach a point of decompensation. And there'll be a significant increase in the intracranial pressure. And it's this event which leads to the dire consequences that can occur in traumatic brain injury, namely brain herniation. As you can recall, the cranial vault is divided into three areas by folds of the dura, called the falx cerebri and the tentorium cerebelli. Now, once the point of decompensation has been reached and the intracranial pressure starts to rise, the extra volume being taken up by a hematoma or other pathology results in the herniation of brain from within these three compartments. This may be in the form of a subfalcine herniation, an uncal herniation, or in the worst case, with continuing increase in the intracranial pressure, it can result in tonsillar herniation, in which the cerebellar tonsils herniate through the foramen magnum, compress the brainstem, and ultimately can lead to brainstem death. So as we'll see later in this tutorial series, our management of patients with traumatic brain injury is aimed at preventing this point of decompensation and subsequent herniation from ever being reached. In terms of the epidemiology of traumatic brain injury, it's a relatively frequent clinical problem, with 69 million cases every year. In fact, traumatic brain injury contributes to worldwide death and disability more than any other trauma-related injury. Whilst it affects all areas of the world, there is a significant variation between developing and developed countries. There's a higher reported incidence of cases in developed areas, such as North America and Europe, as opposed to developing countries, but this may actually be a reflection of a better reporting and capture of data in developed areas, rather than a truly higher incidence of cases. The most common cause of traumatic brain injury is as a result of a road traffic collision, particularly in low and middle income countries. But additionally, in areas of military conflict, traumatic brain injuries are seen with higher frequency and are an unfortunate signature wound of war. Therefore, a lot of the advancements in our knowledge of the pathophysiology and management techniques of traumatic brain injury have come during times of military conflict. Other important causes of traumatic brain injury include falls, in particular in the elderly population, and also assaults and penetrating injuries as a result of gunshots or explosions. When taking a clinical history from a patient, when we're able to do so, or from someone who has witnessed the events, it's important that we understand the history of the trauma in question. So what was the cause and what was the mechanism? As these things can have a direct influence on the subsequent pathophysiological processes and also our management. So for example, we'd want to know if the injury was related to a fall, or was it a penetrating injury? It's not uncommon for patients with traumatic brain injury to suffer from post-traumatic amnesia, and we should try and elicit this feature if it's present. Importantly, we should also be looking for signs and symptoms of increased intracranial pressure, which, as we know, is the serious potential consequence of traumatic brain injury. These can include headaches, vomiting, motor weakness, and a decreased level of consciousness. Patients with significant traumatic brain injury may also have seizures, and also potentially post-concussion syndrome. This is characterized by mood swings, difficulty in concentrating, blurred vision, fatigue, dizziness, and also they may experience personality changes, insomnia, and increased drowsiness. In patients with acute extradural hematomas, there's a classic presentation of the patient experiencing a loss of consciousness, followed by a lucid period as the bleeding continues. And then, once the hematoma has expanded significantly, the patient then becomes less responsive. Some people refer to this sequence in extradural hematoma patients as talk and die, given the fact that during this lucid period, the patients will be talking and acting very normally. However, as the hematoma expands, they will then subsequently lose consciousness, and if we don't act rapidly and appropriately, the intracranial pressure will continue to rise and the brain will herniate, subsequently leading to brainstem death. When we examine patients who've sustained a traumatic brain injury, it's vital that as well as performing a full neurological assessment to assess the power of their limbs, we should also check the size of the pupils and their reactivity. Now, this is really important because, as we mentioned in our section on pathophysiology, and in particular the Monro-Kelly doctrine, with an increased intracranial pressure, once we get to the point where the CSF and blood within the cranial vault can't be reduced any further to prevent decompensation from occurring and the intracranial pressure from escalating, one of the earliest consequences is uncal herniation. Now, from an anatomical perspective, the cranial vault that sits within the area where the uncal herniation will occur is the third cranial nerve, which is involved in controlling pupillary size. So compression of this nerve from the herniating brain tissue can prevent it from functioning. So if a patient comes in who has a unilaterally dilated and fixed pupil, then this is a key indicator that as a result of the raised intracranial pressure, this patient has developed an uncal herniation. And if we don't undertake some urgent management, this problem is going to continue to worsen, and they will ultimately suffer tonsillar herniation and brainstem death. As well as assessing pupillary size and reactivity, we also need to check the patient for evidence of an external head injury. So do they have any lacerations or open wounds, which we need to be aware of and manage accordingly? Additionally, we should also be assessing the patient from a cognitive perspective by checking their speech and their understanding. As well as undertaking a full neurological examination, the most commonly used immediate assessment for a traumatic brain injury patient is the Glasgow Coma Scale, or GCS. This consists of three components: assessing the patient's best eye-opening response, their best motor response, and also their best verbal response. And by assessing and giving a score for each of these three criteria, it allows us to allocate a score of up to 15. Now, we won't go into full detail within this talk about the various individual scoring elements for these three components, but we'll briefly demonstrate it here, so if you want to look at it in more detail, then feel free. However, by assessing these three categories and determining the GCS score, we're able to allocate the traumatic brain injury with a severity classification. If the patient has a GCS between 13 and 15, then they have a mild injury. A score of 9 to 12 is classified as a moderate injury. And finally, a score between 3 and 8 reflects that the patient has a severe traumatic brain injury. An additional element of the traditional GCS, which is a useful adjunct in assessing patients who have traumatic brain injury, is by also including pupillary reaction, which, as we mentioned, is a vital component in our assessment. This amended GCS is referred to as GCSP, and as with the original GCS, is scored out of 15. However, the GCSP score is attained by deducting pupillary reactive score, which is based on the pupil's reaction to light, from the traditional GCS. In cases where both pupils are non-reactive to light, this gives us a PRS score of 2. With one pupil, which is fixed and unreactive, this gives us a score of 1. And when both pupils are reactive, this gives us a score of 0. So you can see how during the initial GCS assessment, a patient may score 13, which would put them in the mild traumatic brain injury classification. But if they are then shown to have one pupil which is unreactive to light, this gives us a PRS score of 1, which we then subtract from the GCS score of 13, and therefore the patient's GCSP score would actually reveal that they have a moderate severity traumatic brain injury. So being aware of the GCS and the GCSP, and the significant role that they both play in the assessment of traumatic brain injury patients, is really important. The investigations we use for patients with traumatic brain injury can be divided, much as the case with any condition, into blood tests and imaging, which in this case is in the form of a CT scan of the brain. Looking at blood tests first, the most important blood tests that we'll be looking at are full blood count, primarily to check the patient's hemoglobin and to look whether they have a low platelet count, and also we would check their coagulation profile to look for any evidence of coagulopathy. The reason for looking at these things is that they are potentially reversible factors that can increase the risk of intracranial bleeding, and also worsen the extent and severity of hematomas. So if we do identify any hematological abnormalities, then it's really important that we remedy them, for example by giving transfusion, as soon as possible. Moving on to CT scans of the brain, these can be done either in isolation or as part of a trauma series. The important things we look for on CT are intracranial hematomas and bleeds, for example, an epidural or extradural hematoma, a subdural hematoma, subarachnoid hemorrhage, and intracerebral bleeding. We can also look for contusions and signs of elevated intracranial pressure, for example, effacement of the basal cisterns, midline shift, or brain herniation. So starting with hematomas, the two most common hematomas that we look for are epidural or extradural hematomas and subdural hematomas. So let's have a look at epidural hematomas first. Epidural or extradural hematomas, as the name suggests, is when bleeding and hematoma formation occurs in the extradural space, between the wall of the skull and the dura mater. This most commonly occurs as a result of bleeding from the middle meningeal artery, which is a branch of the external carotid artery. The middle meningeal artery travels along the inner surface of the skull and acts as the blood supply to the dura mater. The middle meningeal artery gives off an anterior branch, which passes along a region of the skull that is referred to as the pterion. And it's this point that is located behind the temple, where the frontal, parietal, temporal, and sphenoid bones fuse. Anatomically, being the fusion point of so many bones makes the pterion a relatively weak area compared to the rest of the skull. And therefore, significant trauma to this area can cause internal displacement of the bone, in turn injuring the anterior branch of the middle meningeal artery, and thus leading to bleeding into the extradural space. Now, interestingly, the anatomy of the extradural space, and the fact that the dura mater actually fuses with the sutures of the skull, means that the space is compartmentalized, and therefore as the hematoma develops, it can't extend beyond these fusion points. This means that the hematoma actually bulges inwards, and we get a characteristic lenticular shape appearance on the CT scan. On this CT image, we can also see another phenomenon of traumatic brain injury, which is the contre-coup injury. This is essentially when we get an injury on the opposite side of the brain to that which sustained the initial trauma. And in this case, we can see that the contre-coup injury has resulted in a contusion. Contre-coup injuries are important things to look for, and they occur when the force of the trauma results in the sudden movement of the brain away from the affected side, and the brain then collides with the contralateral skull surface, resulting in the injury. Moving on to subdural hematomas, as the name suggests, this bleed occurs in the space below the dura, so between the dura and the arachnoid mater. Subdural hematomas typically occur as a result of trauma causing injury to the bridging vessels which traverse this space. Now, unlike extradural or epidural hematomas, in which the spread of the hematoma is restricted by the fusion of the dura and the sutures of the skull, in subdural hematomas, they do not have this issue, and as a result, the hematoma which develops can actually spread throughout the subdural space. Typically, this results in a crescent-shaped appearing hematoma, which is particularly contrasting to the lenticular-shaped extradural or epidural hematoma that we discussed earlier. This CT image also demonstrates an important feature of raised intracranial pressure in a traumatic brain injury patient, and that's midline shift. Essentially, this occurs when a trauma-related space-occupying pathology, in this case a hematoma, increases the intracranial pressure to such an extent and has such a mass effect that it shifts the ipsilateral brain tissue towards and beyond the midline. This is associated with effacement or compression of the CSF-containing lateral ventricles on the same side, as the CSF gets pushed out of the intracranial space, in keeping with the Monro-Kelly doctrine, in an attempt to control the intracranial pressure. Midline shift is an important indicator of a raised intracranial pressure, and is also an ominous sign, as it's a precursor to brain tissue herniation. So if you ever see midline shift, you should be very concerned. As well as midline shift, another important sign on CT of a raised intracranial pressure is effacement of the basal cistons. The basal cistons are essentially widenings of the subarachnoid system, which contains the CSF. And as the intracranial pressure rises, these cistons become compressed, emptied of their CSF, and ultimately are collapsed or effaced. As with midline shift, effacement of the basal cistons is an ominous indicator of elevated intracranial pressure, and one that warns us that if we don't act rapidly and appropriately, brain tissue herniation will follow. In particular, that of the cerebellar tonsils, leading to brainstem death. And we'll be covering the best ways in which we can manage